Good evening, everyone, and welcome to our webinar tonight. My name is Chandra, and I'm the Ovarian Rejuvenation Technician here at Gen 5 Fertility, and I have the privilege of working very closely with Dr. Wood. I'm excited to be here today, and we have a great webinar coming up about the new concepts of ovarian rejuvenation. Dr. Wood is truly a pioneer. He's done extensive research and has years and years of experience in fertility industry. So let's get started with a little bit about Dr. Wood. He is not only a unique fertility specialist, as you know him, but also a scientist. He's voted one of the top doctors in the US, America's top doctors, rated superb and super doctor. He's the only fertility specialist in the world honored as the who's who in the world, who's who in America, who's who in science and technology, and the recipient of the Marquee Lifetime Achievement and 50 People to Watch. He's also certified as a high complexity laboratory director in molecular diagnostics. He is the director of a reproductive genetics laboratory, featured in the New York Times, BBC, Newsweek, and over 100 television and radio programs. He's a specialist in clients with low prognosis, many unique techniques and protocols he uses. With those special techniques, including platelet-rich plasma, InPlaf, Ultra, and the Ultimate to enhance fertility under challenging circumstances. You'll hear about some of that tonight. He's active in research program with many scientific publications over the past 3 years, and medical director and president of one of the leading fertility centers in the world, Gen 5 Fertility Center. So please use the Q&A box if you have any questions throughout, and we will answer your questions at the end of the presentation. But now I'd like to introduce Dr. Samuel Wood.
All right, so instead of doing my usual talk where I discuss the various details of ovarian rejuvenation and who it works for and who it doesn't work for, I decided to take a completely different approach. Now, some of the things in this seminar similar to what you've seen before if you watch one of my other seminars, but we also have some new perspectives that I think lead toward the future. And later I'll let you know about the next presentation that will specifically look at some of the latest advances in ovarian rejuvenation. So everybody's seen this slide. Look at the effect of age at the bottom of the slide. In terms of fertility, look at how fertility falls, and it falls dramatically beginning at about age 39 and beyond. And by the time a woman's 45, there's almost no fertility left. And if you look at miscarriage rates, they show exactly the opposite effect. As pregnancy rates fall, as fertility falls, miscarriage rates increase. Look how dramatic it is. A 45-year-old woman has an over 90% chance of having a miscarriage if she does become pregnant. But we're trying to help these women have a healthy live birth. So how do we do that? That's what the rest of this talk is about. But first, we're going to look at how does age have this effect on fertility? How does age have this effect on miscarriage rates? Well, first of all, as a woman ages, her egg quality is reduced. Egg numbers fall too, but as we'll soon see, egg numbers falling is relatively unimportant compared to egg quality. And the most important aspect of egg quality is that the percentage of eggs that are made that are genetically normal falls over time. Think about the 90% miscarriage rate if you're 45. The vast majority of the time when you miscarry, it's because the embryo is genetically abnormal. Now, what is egg quality? Many times patients, they come to see me and I say, well, why did all the IVF cycles you've done, why did they fail? And they say, they tell me it's egg quality. Well, what is egg quality? Being genetically normal, as I mentioned, is the most important thing, but there are other elements to it. For example, does it have enough energy to continue to grow and develop and get to the stage where implantation can actually happen? And does the ovary, does the structure that contains the eggs, that helps grow the eggs, does it have a normal architecture? Does it have normal blood flow? is everything normal about that ovary? And we know that as women age, the percentage that have completely normal ovaries falls as well. Now, I think this is one of the most important studies ever done in the fertility field. This is a look at the relationship between AMH and pregnancy rates. Look over here to the left. These are 3 groups of women, and one of them had less than 0.7 AMH. The next group was between 0.7 and 8.4, and the last group had greater than 8.5 AMH, a very high AMH level. Now look over here to the right. The cumulative pregnancy rate, let's just look at 12 months here, was 84% in those with the lowest AMH, and it was 66% with those with the highest AMH level. And I know that may blow you away, because I'm sure if you've ever gone to a fertility center, one of the things they're going to say to you is your AMH is too low. Actually, AMH really has almost nothing to do with it unless the AMH levels are extremely low, which of course does happen. So this is by far the most challenging area of infertility, and many fertility centers want nothing to do with it. 80% of fertility centers have never had a live birth over the age of 42. And so instead, when you go in at age 43 or 44, they're going to tell you don't have a chance. What you should do is use an egg donor. Everything we do here is an attempt to help you avoid having to use an egg donor. You can use an egg donor anytime. Many women want to give themselves every chance before they consider the egg donor option. And so the women that I see have low ovarian reserve. They have few or no quality eggs, no genetically normal embryos for many of them, and prior cycles. They have a very low antral follicle count in AMH. And if they've had implantation, unfortunately, it led to a miscarriage. So their feeling when they come in is, I have poor quality embryos, poor quality eggs, and I have few or no eggs. And nothing, this is the sad thing to me, nothing seems to slow the age-related decline in fertility. And many things have been tried, all kinds of protocols. Growth hormone, extremely common. Taking DHEA, which is a male type hormone, does not seem to work in terms of increasing live birth rates. Many, many supplements are out there that claim that they improve pregnancy rates for women that have low ovarian reserve. They don't do it. There's just no data to support them. So nothing has been shown to do it. And that's why when I became aware of ovarian rejuvenation and some of the things we've done with it, I was so interested, because finally I thought maybe we have something that will help these women. When I meet them, I know they're going to be amazing mothers. And I have this tremendous desire to do whatever it takes to help them succeed. And as we'll see later, we've been able to help many of these women succeed when they were told they had no chance. What does it mean to rejuvenate? It means to make young again, to restore to a former state, to make fresh or new again. And as we've talked about, these eggs are older. They are not rejuvenated in any way. Is there a way to make them younger? Is there a way to increase the likelihood that an egg you make will actually become genetically normal? Because we know when you transfer a genetically normal embryo, the chance of success is very high. So what is ovarian rejuvenation? Well, it's not just one thing. I think when people think of ovarian rejuvenation, they think of it as one of the procedures that we do. And that is one aspect of it. And all of the procedures have to do with platelet-rich plasma and related procedures, except for one. And I'll tell you about that one in a bit. But it's not enough to just do that. So when I first started doing that, we would do these platelet-related procedures, and we would see improvements. For example, an improvement in AMH, more follicles, things like that. But many of these patients went back to whoever they were seeing, whoever they'd done their previous IVF cycles with. They would do the cycle in the same way, and they wouldn't succeed. But it wasn't because of the procedure. It wasn't because of this ovarian rejuvenation procedure. Instead, it was because they were not using an ideal clinical protocol. That's the key. So you have to do pre-treatment. You have to become ready to do the ovarian rejuvenation. You have to become ready to start the IVF cycle to really give yourself a chance at all. And then you've got to do the right type of IVF cycle. So we do several different ones depending on the specifics of that patient. But in general, they involve mini IVF or natural cycle IVF, where they receive no medication at all in the course of the cycle. Or we have unique, novel protocols that we use that we've been very successful with as well. But the commonality of all of these is it's very, very low doses of medication. When you use moderate or high doses, you're not going to succeed, or almost never. And unfortunately, too many doctors do that. They say, look, it's a numbers game. So we're going to give you lots of medications, and we're going to get as many eggs as we can, knowing that a certain percentage of those eggs are normal. But what they're failing to mention is that when you use high doses of medication, what actually happens is the chance of becoming pregnant falls, because the chance that those eggs will be normal is reduced. And we'll look at a study about that in just a moment. And then there's another thing that I don't think we think enough about. It's the effect of sperm. And so women who are older reproductively are typically with men who are older reproductively as well. So it's very common to see sperm abnormalities. In some cases, they can be very significant, and the usual strategies that we use to isolate the highest quality sperm may not work. So it's something important to look at. And if you know there's a problem with the sperm, it should be looked at very carefully. So one of the most important things about ovarian rejuvenation is to understand what I've said. You must start with a normal egg. And so if you begin a cycle, and let's say you have 3 follicles, and each of those follicle is an abnormal egg, you're not going to succeed. It's just not going to work. And ovarian rejuvenation is not going to make them normal, because those eggs actually began to grow 4 to 6 months earlier. And if they started out abnormal, when you start your IVF cycle, they're going to stay abnormal, and they're going to result in an abnormal embryo. That being said, almost all women have normal eggs at any given age. And it's just a question of, can we find those eggs? Can we increase the chance that those eggs will grow and develop and be the ones that we isolate when we do an aspiration? And can we keep those eggs normal once they're out? As they go through the fertilization process and as they go through the embryonic culture process, can we keep them normal? Because there are many things that you can do in an IVF cycle that can increase the chance that that normal egg will become abnormal. And what's sad to me when I look at women that have failed cycle after cycle is that I know with a high degree of likelihood that in some of those cycles, they actually started out with normal eggs, but the protocol that was used when the trigger shot was given, these things may have made a normal egg become abnormal, and thus they lost their chance to succeed. So one of the keys here, no doubt, is luck. You've got to start with the normal egg, as I mentioned. Then do ovarian rejuvenation. I definitely believe that that increases the chance that you'll end up with a normal embryo. And what that does, as we'll see later, is it improves the quality inside the ovary where the eggs are growing. And then you've got to use the right protocol, and you have to work with a center that has an outstanding lab that knows how to keep the embryos normal as they go through the maturation process. So just to recapitulate one more time, if eggs are abnormal to begin with, they're going to be abnormal in the embryo, and nothing can change that. And so the primary reason that someone might do ovarian rejuvenation and feel like there's no response is because, in fact, they started that cycle with normal eggs. And sometimes it is just too late. Sometimes, particularly for women in their late 40s, they simply cannot make enough eggs or high enough quality eggs to have a chance. And when that happens, we have to have a serious talk about that. And I don't like that talk. So we do everything possible to avoid getting in that situation. So again, the whole goal of ovarian rejuvenation is to keep the genetic material in the egg normal before it's fertilized, and then keep it normal during the process of preparing it for eventual implantation. Now, all of this is about the platelet. The platelet, to me, is one of the most astonishing cells in the body. When I was in medical school, no one mentioned the things I'm going to mention today. What they said was the platelet stops bleeding. And that's what we learned. And we learned all the ways it stopped bleeding and all the different abnormalities that would keep the platelet from stopping bleeding. But that's not the most impressive thing it does. Look at this gentleman here who has a rather severe scrape on his right arm. And then watch what happens if you do nothing. If you just simply watch the arm, you wash it, but nothing else, you see how it disappears, how that injury disappears. How does it do it? Well, it's the platelets that do it. Whenever there's an injury, platelets rush to the area of injury and they begin the process of repairing that injury. And how they do this is to release many growth factors in the area of the injury. And in particular, what they do is they stimulate stem cells to grow and develop and to differentiate into all the different cells that are needed to repair that area. If you think about the guy we looked at that had that substantial abrasion, there are lots of different cells that were injured. How can the body repair all those cells at once? Because it stimulates the stem cells for each one of the cells that needs to be repaired. And one of the important things it does is it causes blood vessels to develop. And it does this in the ovaries as well when you inject it. And something that happens as we all age is that the amount of blood flow to various areas of the body is reduced. So it's very important to have an increase in blood flow as well. And I'm not going to go into all the details, but this just shows you some of the growth factors that are released by platelets. And they fall into various categories, but each of these categories has something to do with improving healing in a particular area. In the ovary, as it ages, it needs healing. It does not behave as it did when the woman was younger, and the quality of the follicles that are made is reduced. There are many issues that growth factors and these mitokines and other structures that are here can help. So who is ovarian rejuvenation for? You've heard this before, quite likely, if you've watched one of my seminars. So I'm going to go through it very quickly. So premature ovarian failure, premature ovarian insufficiency, and then there are women who have normal egg production, and they're younger in some cases. But whenever the embryos are tested, they're found to be genetically abnormal. And there's age-related decline in ovarian response as well. And there are lots of names for this: ovarian resistance, insufficiency, poor response, etc. If you're in this area, if you've experienced this, you've heard these words. And then there are women that are perimenopausal and menopausal. And I noted them in red because of something I'm going to discuss with you later. These are by far the most difficult types of cases to help. So there are 5 generations. I'm not going to go through them in detail. Let's just start with generation 1. That's platelet-rich plasma. This was the original procedure. And so you simply take platelets and you activate the platelets. And then you inject the activated platelets into the ovaries. And once a platelet's activated, it releases the growth factors that I mentioned earlier. The second generation is called enriched platelet factors, but over time it's become known as implaf, which is simply one of the major ways of making this material. This works really well. PRP does not work well for age-related infertility. We have many, many babies, many pregnancies from implaf. Generation 3 is a combination of generation 1 and 2. Well, why do we combine them? Well, generation 1 makes far less in the way of growth factors than generation 2, but it lasts longer. And so if you combine generation 1 and 2, the idea is that you'll get a greater concentration of growth factors that also last longer. Generation 4 we call ultimate. Generation 3 was called ultra, by the way. Ultimate also includes ultra, but we add additional elements to it. This is a semi-experimental type of generation, but we now have a good experience with it, and we plan on publishing a paper probably early next year about it. Generation R, you remember the red writing on that slide. Generation R is for women who have undetectable AMH, they have high FSH, and they have no apparent follicles on ultrasound. It's a very, very sad situation. And in this situation, many women decide to use an egg donor, but others say, no, I just want one more chance. I want to try something else. And so we have developed some procedures for Generation R, and we've had some good responses, but as you'd expect, at a low rate. And again, we'll publish something about that probably in 2023 or early 2024. So we'll just go through this quickly. This shows you exactly how these procedures are done. So this is PRP. So the platelets are isolated from the blood. Leaving the activated platelets that are placed in the ovary. This is done under ultrasound guidance. No anesthesia is necessary in the vast majority of cases. So the platelets are incubated for an hour or two, and then we isolate the growth factors, and it's the growth factors and not the platelets that are injected into the ovary. And ultra is the combination of generations 1 and 2. Okay. Now, how do you know which ovarian generation to use? I'm asked this question very commonly. And in the end, it's up to you. As I've mentioned, I think for age-related infertility, it doesn't make much sense to do anything less than generation 2. And so generation 2 or 3 is what most people choose. And when we see you, we'll go through details about those to help you make the right decision for you. And these are some of the other variables that we look at before deciding which of the generations to recommend for you. So it's also very common after doing ovarian rejuvenation, as you might guess, for patients to say, well, did it work? Did it help me? Well, there are lots of things you can look at. And I'm starting with the least important up to the most important. You can look at AMH. In roughly 30% of patients, we'll see an increase in their AMH. You can also look at the antral follicle count. So a little higher percentage than that, we'll see more follicles develop. You can look at the FSH level. For many women, the FSH level is high. And after they do ovarian rejuvenation, then it goes back down to a more normal level. You can look at the eggs that are made, at the embryos that develop. You can look at the quality of them. Prior to ovarian rejuvenation procedure, it's actually fairly common for the embryo not to be able to get to the blastocyst stage. And obviously, if you don't get to the blastocyst stage, you really can't have implantation. You can look at the percent of embryos that actually become blastocyst, and you can also look at the appearance of the blastocyst. And the most common technique is to say it's an AA or a BB or an AB, that sort of thing. And we give you a picture of each of your blastocysts, and we let you know what grade it is. But the most important thing really is whether or not they're genetically normal. So once an embryo gets to roughly day 5 or 6, and it's a blastocyst, a few cells are removed from each embryo, and they're sent to a reproductive genetics lab. And then 7 to 10 days later, we get the results back, and we know which embryos are normal, which are abnormal, which are male, which are female, so you can make the right choice for you about which embryo to transfer, assuming you have a normal embryo or assuming that you have an abnormal embryo, but it's just certain abnormalities which are fine to transfer. In the end, obviously, pregnancy is even more important, and then the delivery of a healthy baby. That's what we all want. That's why we do this. And that's the ultimate goal of ovarian rejuvenation. So what happens after an ovarian rejuvenation procedure? What do people do? Well, some have spontaneous attempts at pregnancy, and I'll show you some data about that in a few minutes. Others do stimulation medications and intrauterine insemination. In general, we don't recommend that because for reasons that aren't entirely clear, IUI works very poorly for women who are older reproductively. Others do IVF, and as I've mentioned, it's either mini IVF, natural cycle IVF, low dose conventional, rarely. I almost never use this now because the chance of getting a normal embryo out of that type of cycle is very, very low. And we also have those novel, unique type of protocols that I mentioned before. Using the right protocol for the right patient is absolutely essential if our goal is to get genetically normal embryos. Okay, let's look at this. I think this is so profoundly important, this study, and unfortunately, it's routinely ignored by fertility specialists. So let's look at the column that has 1 to 5 at the top. What that means is that 1 to 5 eggs were retrieved. And if you look along the left side where it says FSH dose, you can see that there's a steadily increasing dose of FSH. Now, this is the total FSH that's used throughout the cycle. And it begins at less than 1,000, and then 1,000 to 2,000, and 1,000 to 3,000. It's actually very common to see 3,000 to 4,000 units or more given to women who have low ovarian reserve. But if you look here, what you see is that the pregnancy rates progressively fall. And at the lowest level, sorry about that, at the lowest level, 48% pregnancy rate. And at the highest level of stimulation, it drops to 32%. And this is true across all numbers of eggs retrieved. If you look under the all column, this is the effect when you add everything together, and you can see that the live birth rate is 35% with low doses and really no effect of 1 to 2,000, which is what we generally use. And it falls as low as 23.7% at the highest doses. So there is no excuse of any kind to use high doses of medication on women who are going through this. So I have not shown this slide before, but I think it's valuable for you to see how things really go, how the entire pathway goes. So in general, I meet someone in person in the office, or I do phone consults. I do phone consults every day, and I speak to women from around the country and the world about ovarian rejuvenation and whether or not it's right for them. Then they speak to someone who schedules them for a procedure and sends them information about the things they need to do to prepare for the procedure and supplements that they need to take. Then we either look at the blood work that they already have if they've had it recently, or we obtain new blood work so that we can see where they are before they come for the ovarian rejuvenation. And in many cases, once we look at those levels, we see that they need pre-treatment in order to have the greatest chance of responding to the ovarian rejuvenation. And then we do the ovarian rejuvenation procedure, and we do a full set of baseline blood levels that we use for the future to look at what effects we can see from the ovarian rejuvenation. Now, once we do the ovarian rejuvenation procedure, usually patients begin their IVF cycle roughly 4 weeks later. Others choose to wait. They choose to try spontaneously. In that case, we follow up with them on a monthly basis to recheck the lab values that we drew before they had their first procedure. I've discussed this before. I want to just mention it very briefly. I think NMN is quite likely the most important supplement to take if you're trying to become pregnant and you have low ovarian reserve. And if you look below at this study, it looked at one of the main measures of quality in a blastocyst, which is the number of cells that are present within a portion of the blastocyst. And on the far left-hand side in blue, you can see the number of cells when the mice, this is mice, by the way, when the mice were untreated was low. And then over the next 28 days, the number of cells, these critically important cells, went up dramatically. And this is something that we have all of our patients take, no matter what generation OR they're going to do, and no matter how they plan on trying to become pregnant later. And we've seen a substantial number of good results from this. Now, one of the things you have to remember is NMN, just like every other supplement, in many cases is fake. So you have to make sure that you're using one that is true NMN. And we'll send you a link that shows you exactly which ones are truly fully efficacious. And those are the ones that you should buy. But if you just go online and buy an NMN, there's a very high chance, actually around 80%, that the NMN that's in that sample will not be real. And it's critical to take the real thing. So there are many, many examples of success. Here's somebody who was 44 years old. She did implant. Her AMH started out at 0.21, a very, very low level, and she was successful in having a baby. Here's a 43-year-old, 4 previous failed IVF cycles. Her AMH was 0.08, extremely low. Her FSH was 30. She did ultra. She got 1 egg, 1 normal embryo, and has an ongoing pregnancy. Last year, I think we probably had 5 or 6 women who are either pregnant now or who had a baby from 1 follicle with 1 egg. And that's what it's all about. It doesn't matter how many eggs you get. As I mentioned earlier, what matters is, are they genetically normal? Were they well taken care of during the cycle? And then the last one on this sheet, she was 43, 11 years of infertility. She had 6 previous failed IVF cycles. In fact, she had never made a normal embryo. In 11 years, never made a normal embryo. She did implant prior to doing her IVF. She created 1 normal embryo and has an ongoing pregnancy. But what's even more interesting to me is the next slide. These are spontaneous successes. We've now had four successes in people that tried to become pregnant spontaneously after doing one of these OR procedures. And here's one example, 43 years old. She had implant done in December of 2021. She became pregnant by February 8th and had an ultrasound showing a healthy pregnancy. Previously, she had done 5 to 6 IVF cycles and had never even made it to egg retrieval. And you want to know why? Because the other center refused to do an egg retrieval unless many eggs were available. So she would create 1 follicle, they would not do the procedure, and she had never succeeded. Look at her AMH level, 0.039, extremely low. The FSH level, and the general rule is you never want it to be above 18. Hers was almost 24. Her LH was 55, almost 56. And she was able to become pregnant within 4 to 6 weeks of doing ovarian rejuvenation. And as I mentioned, we have 3 other cases that are similar. Now, does everyone succeed when they do it? Absolutely not. This is no magical cure, anything like that. This is for women that want to give themselves a chance. This is for women who have been told you have to use an egg donor, but they don't want to do that. They want another chance. They want to do everything possible in order to succeed. But some women just do not respond, or they do respond, but they don't make normal blastocysts. And we don't know exactly why they don't respond, but it can happen even with increased AMH and antral follicle count. You can see other signs of improvement, but in the end, when you test the embryos, they're not normal. Now, what do you do if there's no success? Well, you can repeat ovarian rejuvenation. In general, we don't recommend it, But in some cases, it makes sense. Someone has responded well to the ovarian rejuvenation, but they have not yet made that normal embryo. So in those kinds of cases, and they're fairly rare, it's reasonable to do it again. And also, whenever you do an IVF cycle, if you look carefully at it, you can almost always see things that could have been done better. So we look very carefully at any IVF cycle that fails. We have a meeting with the IVF lab and we get their views. And we look at what can be done better in the next cycle so we can increase the chance of success. Remembering, as I said, that unless we start with that normal egg, it will not work. And sometimes, after some length of time, some women do need to use egg donation. And none of us like it. However, we know that it's true, and we keep a close eye on that. And if we see that things are heading that direction, we'll speak with you about it. And so the other question I get asked a lot is, will I succeed? If you look at my characteristics, do they tell you that I'm going to succeed or that I have a high chance of success? As I've said, the most critical thing is, do you have normal eggs in that particular cycle? Did you do pre-treatment? Pre-treatment is essential to success. Was the protocol that we used or someone else used, was it ideal for you? Was the surge done at the correct time? It is very common to miss the ideal time to do the surge. And when you do that, the chance of success falls dramatically. Now, anyone who knows me knows that I'm constantly thinking, I'm constantly coming up with new ideas, new ways to put things together to increase the chance of success. And there's several possibilities, and there's some I don't even include on this list. For example, some natural fertility methods that are available are interesting to me. Actually injecting HCG into the uterus is interesting. Red light therapy. There's several different supplements that may have some benefit. Intralipids. I'm a big fan of intralipids. IV infusions, for example, things like NAD+ and glutathione. Meditation and visualization. I think that can be very helpful for a select group of women as well, and diet. So what I'm going to do is I'm actually going to use my next seminar to discuss these more unusual methods that are used and to look specifically at the data and find out if there's anything to support these methods so you can decide which one would be right for you. And as I mentioned, nobody starts out wanting to do egg donation, but if you come to that, we do have a large egg donation program. And I'm very proud of how we do things because in general, if you want a choice of a large group of donors, you have to use frozen eggs. And frozen eggs are certainly inferior to fresh eggs. So the way we do it, you can actually use fresh eggs, but not have to take the entire batch, which is extremely expensive to do. So if you ever get there, we'll be happy to go through that with you. So this is our primary focus on research. If you look on the website and there's a tab on the far right that says research, you'll see several papers about ovarian rejuvenation, and you'll see other papers that are in areas that are interesting to us as well. But this is my primary focus when it comes to research as well as my clinical activities. And so we do special things for women that are in this situation. How the stimulation cycle is done, which medications are given, what days are they given those medications. If they're going to be given growth hormone, are there ways of telling whether or not they actually need growth hormone? And it turns out there are. You can get your blood drawn and you can tell with a high likelihood whether or not you need to take growth hormone. When should the growth hormone start? There are many questions related to that that can affect the final outcome of a cycle. And how are the eggs and embryos managed in the lab? This is something that I constantly stress. I feel so lucky to have an outstanding lab really focuses on this, focuses on the best ways of caring for these precious embryos. How is the progesterone given? How much progesterone is given? When is the embryo transfer done? How is the embryo transfer done? All of these are decisions that can be made that can have a profound effect on the quality of the cycle. And right now, another thing we're doing is working on a completely different way of doing PGS or PGTA that I believe will markedly improve the prognosis, but it's too early to say. It's still ongoing research. Once we have more data, I'll tell you about that. As I mentioned, we publish many papers. It's very important to us. And you can see most of them right there under research. You can actually download the papers and read them if you wish. This is our center. We're very proud of our center. And in the distance, you can actually see the Pacific Ocean right here. And this is Torrey Pines State Park, which is one of the most amazing state parks in the country. And we're very proud to be a part of it. But in the end, what really matters are the babies. And I love these babies. And I love when I see them again after the delivery. People bring babies back, and that means so much to me. We work so hard every day to make this work. And when you see these babies, that is the ultimate reward. Well, thank you so much for your attention. And now I will click on this button, and with any luck, Shani will be there and we'll go through whatever questions you ask. It worked.
Thank you again, Dr. Wood, for your presentation. And it's great to see so many questions from around the world, around the US. We'll get to as many of them as we can.